A 32-year-old female presents with 3 weeks of voluminous, watery diarrhea occurring 10 to 12 times a day, including nocturnal episodes. Despite these severe disruptive symptoms, the patient has a completely normal physical examination, unremarkable laboratory results, and a prior colonoscopy that showed no abnormalities. When an exhaustive organic workup is negative in the presence of persistent, large-volume diarrhea, the differential must immediately pivot to factitious diarrhea. Factitious diarrhea involves the intentional falsification of illness. Patients typically achieve this by either abusing laxatives or directly adding fluid to their stool. Normally, stool osmolality maintains equilibrium with plasma osmolality. If altered, a drop into hypoosmolality indicates added water, while a spike into hyperosmolality suggests added urine. Furthermore, osmotic laxatives create a high stool osmotic gap, whereas secretory laxatives, like Senna, produce a low gap. Unexplained chronic diarrhea paired with a normal organic workup mandates a shift away from invasive scoping. The required next step is stool chemistry analysis to rule out self-imposed illness. An 80-year-old female with advanced Alzheimer's dementia experiences recurrent daily watery diarrhea at home. However, upon hospital admission, her symptoms rapidly resolve with only supportive care. This pattern reveals a critical dependency. Her symptoms are tied entirely to her home environment and the presence of her primary caregiver, resolving as soon as the patient is admitted to the hospital. This medical illustration of the patient's colonoscopy reveals a condition known as melanosis coli. We see a cross-section of colonic mucosa highlighting the accumulation of dark brown lipofuscin pigment within the lamina propria. Melanosis coli is the pathophysiological result of colonic epithelial damage from chronic anthraquinone laxative abuse, such as Senna. This structural damage takes several months of continuous abuse to develop. This chronic presentation is accompanied by the laboratory finding of metabolic alkalosis. Over months of abuse, the body attempts to compensate by decreasing intestinal bicarbonate excretion. This contrasts sharply with acute diarrheal illnesses, which typically present with metabolic acidosis due to rapid, uncompensated intestinal bicarbonate loss. These findings point to factitious disorder imposed on another, or FDIA. The perpetrator is motivated by a psychological desire to assume the caregiver role, not by external financial gain. The discovery of melanosis coli in a vulnerable, dependent patient shifts the situation from a medical mystery to a safeguarding emergency, requiring immediate notification of adult protective services. A 22-year-old male presents with progressive burning sensations in his hands and feet, a sore mouth, intermittent bloating, and microcytic anemia. Looking at this anatomical diagram, we can map the sensory loss in a symmetric stocking glove distribution over the distal extremities. This pattern categorizes his neurological symptoms as a length-dependent axonal polyneuropathy. The patient's sore mouth connects directly to atrophic glossitis, documented on physical exam as a markedly red, smooth tongue. The combination of polyneuropathy, atrophic glossitis, and microcytic anemia in the presence of mild gastrointestinal symptoms points towards celiac disease. This microscopic video demonstrates the core pathophysiology of celiac disease. An autoimmune response to gliadin triggers intense inflammation in the small intestine, causing healthy finger-like villi to rapidly blunt and flatten into a damaged surface. The systemic extraintestinal manifestations, such as peripheral neuropathy, are driven primarily by systemic autoantibody production, rather than secondary nutritional deficiencies. Consequently, these neurological signs can actually precede severe malabsorption. We can rule out alcohol-induced toxic neuropathy based on the patient's young age and history of low alcohol consumption. Diabetic neuropathy is also ruled out due to the complete absence of metabolic risk factors or symptoms like polyuria, which is excessive urination. The most appropriate next step in diagnosis is an assay for tissue transglutaminase IgA antibodies. Celiac disease acts as a systemic autoimmune disorder, manifesting through idiopathic distal neuropathy and early mucocutaneous signs, long before it presents as a classic localized bowel disease. A 22-year-old male develops acute scleral icterus, yellowing of the eyes, following a viral upper respiratory infection. His physical examination is otherwise completely normal. His laboratory results reveal an isolated indirect or unconjugated hyperbilirubinemia. We rule out infection-induced hemolytic anemia because the patient has normal hemoglobin levels and a normal reticulocyte count, which measures the production of young red blood cells. We also rule out acute viral hepatitis by noting the completely normal levels of aspartate aminotransferase and alanine aminotransferase, the primary liver enzymes known as AST and ALT. This leaves Gilbert syndrome, the most common inherited disorder of bilirubin metabolism. This biochemical flowchart illustrates the mechanism. Inside the hepatocyte, there's decreased activity of the enzyme UDP glucuronylyl transferase. The conjugation process fails, and unconjugated bilirubin accumulates. This deficiency is asymptomatic until provoked by stressors like a febrile illness, fasting, exercise, or dehydration. Stress-induced isolated indirect hyperbilirubinemia paired with normal liver enzymes indicates a benign genetic condition requiring patient reassurance rather than invasive clinical intervention. A 38-year-old male with moderate intellectual disability from Down syndrome develops acute, severe constipation characterized by hard stools and straining. Constipation is highly prevalent in intellectually disabled populations due to physical immobility and medication side effects. However, this patient's acute presentation requires deeper investigation. We first check for confounding pharmacological factors. The patient takes no anticholinergic or antipsychotic medications that could suppress bowel function. We also confirm the absence of structural alarm features, pointing out the normal physical exam, normal digital rectal exam, and negative fecal occult blood test. Focusing on the metabolic branch, Down syndrome patients possess an increased baseline risk for endocrine abnormalities. Hypothyroidism drives secondary constipation through decreased gastrointestinal motility. We must contrast this adult presentation with Hirschsprung disease, which classically presents in the neonatal period, not the fourth decade of life. Beyond basic hydration and dietary fiber, the most appropriate next step in management is ordering thyroid function studies. An acute change in bowel habits in a high-risk syndromic patient necessitates immediate laboratory assessment for metabolic failure before defaulting to functional or surgical etiologies.